Prolactin is produced primarily by lactotroph cells in the anterior pituitary. Its normal serum concentration is about 10 to 25, and it has a relatively short half-life of about 20 minutes. It's metabolized by the liver and kidneys. Because of this, the liver or kidney disease or dysfunction can lead to elevated prolactin, even in the absence of pituitary pathology. Prolactin is essential for lactation and inhibits reproductive function. It suppresses GnRH, leading to decreased FSH and LH, which is why lactating individuals often experience amenorrhea. This lactational suppression of ovulation is nature's way of spacing out pregnancies, although it's not a perfectly reliable contraceptive. Prolactin secretion is primarily inhibited, not stimulated, by dopamine from the hypothalamus. Anything that reduces dopamine inhibition can lead to hyperprolactinemia. Estrogen increases prolactin synthesis, which is why levels rise during pregnancy. Prolactin also rises with sleep, physical or emotional stress, and nipple stimulation. Medications that block dopamine, such as antipsychotics, are common causes of elevated prolactin. Elevated prolactin can cause amenorrhea, galactorrhea, infertility, and decreased libido. It's commonly seen with pituitary adenomas, especially prolactinomas, but also with hypothyroidism, stress, and many medications. AFAB individuals on estrogen therapy or oral contraceptives may also have mild elevations. When prolactin is significantly elevated, imaging the pituitary is often warranted. When an individual presents with amenorrhea and absent or underdeveloped secondary sexual characteristics, this strongly suggests an early issue in the hypothalamic pituitary gonadal axis. High FSH generally indicates gonadal dysgenesis, such as Turner syndrome. Low or normal FSH suggests hypothalamic or pituitary failure. These cases require evaluation for primary ovarian insufficiency, POI, congenital anomalies, chronic illness, and potential pituitary pathologies. For secondary amenorrhea, the first step is always ruling out pregnancy. Other common physiologic causes include lactation, excessive exercise, significant weight loss, or systemic illness. If none apply, hormonal testing is indicated. FSH, LH, prolactin, testosterone, estradiol, and sometimes even TSH. These values can help map out where the disruption's occurring. Is it ovarian, pituitary, or hypothalamus? When secondary sexual characteristics are normal, estrogen exposure has occurred. This means the ovaries have functioned at some point. Initial labs would include FSH, LH, prolactin, and TSH, followed by a Provera challenge test. Bleeding after Provera suggests estrogen is present but ovulation is absent, common in PCOS or mild hypothalamic dysfunction. No withdrawal bleed raises concern for low estrogen outflow tract abnormalities. FSH helps distinguish ovarian failure from central causes. High FSH suggests primary ovarian insufficiency, while normal or low levels point to hypothalamic pituitary causes. If the patient is under 25 years old with high FSH, karyotyping is recommended. If under 35, consider an autoimmune etiology. In low FSH states, evaluate for pituitary tumors, chronic illness, disordered eating, or stress-related suppression. A high prolactin suppresses GnRH, which can lead to decreased LH and FSH and ultimately amenorrhea. Common causes include pregnancy, lactation, hypothyroidism, stress, and even medications, especially dopamine antagonists or pituitary adenomas. Macroprolactin, which is prolactin bound to IgG, can elevate measured levels, but is often clinically insignificant. Persistent evaluation warrants pituitary imaging to rule out an adenoma. Hypothyroidism is a key, often overlooked cause of hyperprolactinemia, as low thyroid hormone increases TRH production, which stimulates prolactin release. This mechanism can produce menstrual irregularities, galactorrhea, and infertility. Correcting hypothyroidism typically normalizes prolactin levels and restores normal healthy menstrual function. For individuals with regular cycles, ovulation is likely occurring. A mid-luteal progesterone measured on day 21 of a 28-day cycle confirms ovulation if it's greater than 25. If cycles are irregular, progesterone should be checked weekly until 7 days before expected menses. If ovulation is confirmed, further hormone testing is usually unnecessary. If progesterone levels remain low across several cycles, additional testing is indicated. Day 2 to 5 labs should include FSH, LH, prolactin, testosterone, estradiol, and potentially TSH. These tests help to identify anovulation, luteal phase defects, hyperprolactinemia, thyroid disorders, and/or hyperandrogenic states like PCOS. In individuals, this is showing for our patients that have an AMAB individual with unexplained male infertility, looking at kind of what we would consider. So we would consider an unexplained male infertility. What is the expectant kind of process? And it's doing a sperm cervical fluid test. So collecting um, ejaculate and analyzing sperm function. And there's lots of sperm function testing. And there are also sperm motility testing that can be completed as well. In individuals over 45, a typical menopausal symptom with irregular cycles generally does not require testing, but if atypical, such as early onset or unusual symptom patterns, FSH and LH on cycle days, so days 2 to 5, can help determine the stage. If FSH levels above 30, we consider perimenopause, although FSH can fluctuate. For those under 45 years old, persistently high FSH on two tests, 8 weeks apart, suggests premature ovarian failure. When someone under 45 then has an elevated FSH and symptoms of ovarian insufficiency, the differential includes early perimenopause or premature ovarian failure. For those under 35, autoimmune causes or genetic etiologies should be considered. Estradiol typically remains normal until late perimenopause, so pairing estradiol levels with FSH can help clarify the diagnosis. So ultimately, this kind of slide is trying to help summarize the major testing patterns for AFAB hormonal evaluation. For primary amenorrhea, the essential tests are FSH and LH. For secondary amenorrhea or oligomenorrhea, a more comprehensive hormone panel is needed, including prolactin, testosterone, and estradiol. For hyperandrogenic symptoms like hirsutism or suspected PCOS, testosterone on days 2 to 5 is key. And in atypical menopausal symptoms, FSH, LH can help differentiate perimenopause from premature ovarian insufficiency. And this is just showing our beautiful broad endocrine review of our hypothalamic hormones, such as gonadotropin releasing hormone, corticotropin releasing hormone, thyrotropin releasing hormone, and growth releasing hormone, and how they act on the pituitary to stimulate downstream hormonal release. And these regulatory factors set the stage for coordinated control of reproductive, metabolic, and stress-related pathways. We can also see here, this is another image showing similar, showing the what our pituitary gland is producing and how these hormones are targeting specific glands and causing specific functions and specific releases.